Everyone. Welcome to this trilogy 5 session, Primary Ovarian Insufficiency. So my name is Satoko Osuka from Aichi University, Aichi Medical University. So today, I'm very honored to do this session co-chair with Professor Joe Lee Simpson. He is the past president of IFFS. And fortunately, we have 3 world-leading experts or POI for this session speakers. And I believe they guide us to the new findings of mechanisms and clinical guidelines and emerging treatment for POI. So Professor Prot, please introduce the first.
Thank you very much, Professor Osuka. It's a pleasure to be a co-chair of this particular session for a number of reasons. It's a field, premature ovarian failure, its explanation and its frequency, in which we have finally gotten to some solid information that could be applied to help our patients who could be at increased risk and even could profit from clinical trials in areas like this. Our first speaker is Yingying Chen, who's from Shandong University in Jinan, China. I have known her for quite a long time because Alex Rajkovic, professor who has already spoken at this meeting, and I were the leaders who inherited from Zijing Chen, her mentor, back in Jinan and Shanghai, in terms of sending Yingying to America, to Houston to be exact, for postgraduate training. The rest is history. You know, I spent a number of years believing that ovarian failure, premature ovarian failure, was due to chromosomal abnormalities or even mosaicism. It only took a few years from Yingying to prove that I was incorrect, and that she realizes that there are autosomal genes rather than X chromosome genes that are pivotal. So it's a privilege, and it's always a privilege to hear the spectacular work and its lengthy availability for this session. So Yingying, the precise title is already on the screen: Genomic Stability Maintenance and Ovarian Aging. Yingying?
Okay. Thanks for the introduction by Professor Simpson, and thanks for your coming, and thanks for invitation from FFS. So today my topic is about the genomic stability maintenance and overaging. It's a basic research in this field in the last few years. So I have no financial relationship to disclose. So today's content includes 4 parts. The first one is I want to introduce in brief about the characteristics of oocyte genome. And the second one, I want to discuss some progress about how genomic instability regulates the ovarian agent. And the third part is how about the effect of oocyte genomic instability on offspring health. And the last one, based on so many studies on mechanism, so there's some exploration on how to delay the overaging targeting on genomic instability. So the first part. So as is known, the ovarian aging occurs earlier than other organs in our body. It often begins at 35 years old. And also we know that in the aged ovary, a decline in both quantity and quality will impair the female's infertility and its fidelity significantly. So the 9 hallmarks of ovarian aging have been proposed this year by a Chinese researcher. So there are 3 types of hallmarks. That is primary, antagonistic, and integrative hallmarks. Among them, the primary hallmarks are considered as the fundamental causes for ovarian aging. It includes the progressive declination in genome, epigenome, and organelle impairment. So today I want to introduce the genomic instability during the overaging. Firstly, I want to introduce the mechanism for maintaining genomic stability in cell, not only in the gametes, but also in the somatic cells. So when the DNA damage occurs in the cell genome, the cells sense the damage and initiate signaling transduction and activate their DNA damage response. Here I operate at DDR pathway. The common DDR pathway includes the ATM check2 and ATR check1 pathway. So the DNA repair pathways coordinate with the cell cycle regulation and to repair the DNA damage. If the damage cannot be repaired completely, the accumulated genomic mutation will cause the cell undergo senescence or apoptosis. Also, if this unrepaired DNA damage occurred in the oocytes or in the gametes, it will affect the development of the gamete and also even on the health of the offspring. So there are some other special or distinct characteristics of the oocyte genome. After all, it's not a somatic cells. So there are two features of the oocyte genomes. The first is the stability. It is reported that the mutation rate in gametes is only 1% of the somatic cells. That means the low mutation rate to ensure the species continuity. At the same time, it also has another feature is flexibility. What's that mean? That means during the meiosis, the homologous recombination will promote the crossover between the paternal and the maternal chromosome to achieve genetic diversity. So here is the question: how do the oocytes to maintain the intricate balance before the stability and the flexibility? So there are two mechanisms. The first one is the high fidelity repair. We know during the meiosis, the HR, homologous recombination process, repair capacity to restore its integrity of the genome. At the same time, the oocytes are equipped with a strict surveillance system. That means it's low tolerance for DNA damage, and the damaged oocyte will be eliminated by apoptosis. And to avoid the transmission, the damage of the DNA or the genome material between intergenerational. So next, I want to introduce some studies about how the genome instability regulates, or we call drives overaging. Actually, there have many population studies in the last few years. So I want to introduce the genes belong to DDR pathways and how the variants, the common variants, the rare variants find in the women, how to affect the age of natural menopause. And also I want to introduce our group's study about the causal variants identified in premature ovarian insufficiency. Yeah, so the first part is about the common variants in DDR genes identified associated with the physiological overaging. It's from a study in 2021 from the published in Nature. So it's a large cohort, large-scale GWAS studies and identified over 200 SCP loci associated with age of natural menopause. So we defined this variants pathway, and we can see 2 to 3 of the loci are related to DDR pathway, especially involved in the replication stress response, the DNA damage, recognition, repair, and apoptosis as well. So last year, also published in Nature, so the whole exome sequence were performed in over 10,000 postmenopausal women in UK Biobank. And we know GWAS screened the common variant that we call the SNP, where the whole exome sequence, we can screen the co-reading region of the whole genome. So it will identify the real variants in DDR genes associated with the overaging. So real variants in 9 genes were identified to be associated with the age of natural menopause, and 7 of them that I circled in red, and we can see they also belong to DDR genes, and especially the 3rd gene in the bold red circle, they are first identified to responsible for ovarian aging. So these are about two studies from the general population. That means to study the relationship before the DDR genes and their age of natural menopause. So what about the disease? I mean the premature ovarian insufficiency. So we also performed the whole exome sequence in over 10,000 patients, POR patients, and we found the pathological variants of DDR genes. And the genetic contribution to this disease is up to over 20%. So also we performed the pathway analysis, and we see that the variants are significantly enriched in DDR pathways, especially in HR pathway and in Fanconi anemia pathways. So maybe you are very curious why Fanconi anemia, it's a chronic disease pathway, responsible pathway, why it is related with POR, why it is related with overaging. Next, I will introduce this in detail. So here is the 100. I think this gene maybe up to the end of last year. Nowadays, maybe this number will be increased as well. So there are 170 PR curative genes, and we can say it covered all the process, process of follicular genesis. And you maybe pay attention to the red genes. They all belong to DDR pathways. It accounting for 30% of the whole curative genes. And also we can say these genes are mostly involved in the PGC proliferation and the meiosis process. So next, I will select a few representative genes of the DDR genes during the PGC proliferation and meiosis, and also follicle development to introduce their roles during the ovarian aging maintenance. So the first gene I want to introduce is the about PGC replication process. So we first found that during the PGC proliferation, high levels of replication and transcription induce frequently TRC. Here means the transcription replication conflicts in the PGC, because the transcription and the replication share the same DNA template, so it's inevitably occurred the TRC as a conflict at the loci. So the high levels of TRC induce increased endogenous replication stress in PGC, indicated by the increased I loop formation and the decreased replication speed. So at the same time, we found that the Fanconi anemia pathway is constitutively activated at the TRC loci in S-phase PGC. And we knock out a few genes of the FA pathway, and we saw that loss of FA pathway activity will lead to a significant increase in TRC frequency and elevated I loop levels, and ultimately will result the affect the PGC replication as well. So that's why we this study provides a common explanation for our observation in clinic. Many of the FA patients suffered from their infertility and lower ovarian reserve, and also we know there are 22 genes among the FA pathway family, and 20 of them, when we knock out 20 of their genes, the mouse will, the phenotype of the mouse is also infertility and the follicle loss after birth. So it's a very interesting study. Another gene about PGC replication is MCM8. As is known, it's a very famous gene during meiosis for HR. But our study, we found that MCM8 deficiency causes cell cycle abnormalities and unrepaired DNA damage accumulated in PGC. So it suggests, it hints that maybe this gene not only involved in meiosis HR process, maybe it also has a role during PGC proliferations. So further mechanism study confirmed that the MCM8 could interact with the DDX5 and the DHX9 and to remote the resolution of eye loops. So the MCM8 maintains the genomic stability of PGC as well. So we further mimic the mutants identified in POI patients, curative mutants. And we found that the mutant MCM8 also showed the impaired interaction with the DDX5 and result in increased eye loop levels. So this study, I called it as old gene but new mechanism. So it's maybe some gene we think, yeah, we take it for granted, yeah, it is HR gene, it's a meiosis gene, but sometimes our basic study will give us more surprise or more explanation for this disease. The second part about gene is about meiosis. As is known, the HR repair during meiosis guarantees oocyte genomic stability. So there are 4 processes about HR, including ending processing, invasion, and Holly junction formation and resolution. Many genes have been studied in mice. So here I subgrouped these genes according to their function during this process. And we can say, also I showed the phenotype of the KO mouse. And we can say most HR gene defects will lead to female infertility. But most of them present with the progressive follicle loss after birth. But also, if genes participated in the resolution, will result in the aneuploid oocytes and embryos. That means the patient may be suffered from the abortion or the birth defect. So also some genes are labeled here in red because these genes are non-meiosis specific HR genes. That means these genes also participate in the somatic DSB repair process. So when this gene were knocked out, we can say it's not only the fertility defect, it also presented with embryonic lethality, developmental abnormalities, and cancer risk. So different genes, although these genes all belong to the HR process pathway, but different function, different gene will result in different phenotypes. So we'll see what about these genes in human, in POR patients, what's their manifestations in humans. We can see it's similar to the mouse. We can see I labeled these genes in blue. They are meiotic specific HR genes. So when women carry the least genes mutation, and the women will exhibit isolated POR, only ovarian phenotype. On the contrary, and the defects in the rest non-meiosis specific HR gene, it will cause anemia and tumor risk. So that's why I remember after yesterday talk, Professor Simpson asked me about the panel screening in clinic. So it's very important. If a patient carries the mutation about BRCA2, it's very famous. So we should not only care about their ovarian function, we also should suggest a long follow-up of their tumor risk. And I think this is why we perform the genetic study and why we want to know what's the mechanism of this mutation in this patient. So the last gene is about TP63. This is also from our group. And this gene, we found 6 hetero mutations in our 1030 West data. And we found that the mutation is a gain of function mutation. What's that mean? So the mutation will result in the terra formation and activate this protein. So and it's a constitutive activation of the mutant proteins. And the mutations will lead to increased spontaneous apoptosis in the oocytes. Even the oocyte is not damaged, it will be destroyed because of the activation of TP63 when the women carried this mutation and causing accelerated follicle depletion and POI. So it's very different mechanism during POI process. So make a summary, and we can say whether the gene mutation or gene function defect during the oogenesis, during the embryo, such as the PGC proliferation or the program DSB during meiosis, or some other defect after the birth. That means the apoptosis or the depletion of the follicle is accelerated, will result in the POR disease. And also, all this means the genomic instability is a can cause for overaging. So the third part is about the effect of oocyte genomic instability on offspring health. Maybe some delicate may say, yeah, we know the genome instability will result in aneuploidy. Yes, and this we observed in clinic. So in aged women, we observed that the decreased DNA damage repair efficiency and the DNA damage accumulation in the oocytes, and that will result in early miscarriages and birth defects. And also, this is a well-known phenomenon, and also it's a well-known a theory. Actually, yesterday I listened to a very interesting talk. Is about the meiosis cohensin increase with the aged woman, and will result in the a new mechanism about the trisomy of small chromosome. It's very interesting. So. Besides that, I want to talk about the increased de novo mutation rates in offspring from elder parents. This published in about 10 years ago, but it's very interesting. And we can say, except for chromosome abnormalities, and we can say that de novo mutations induced developmental disorders in offspring account for approximately 1 to 3 birth defects. And also, whether de novo mutation occurs in maternal, it may be associated with cumulative DNA damage, and in the paternal, de novo mutations are likely due to replication errors. We know the sperm will mitosis and when they grow up as well. So this is a new publication last year in Nature, and it's performed the whole genome sequence in over 8,000 trials, and it's very interesting. And we can see the increased de novo mutation in the offsprings from the women who genetically proposed to overaging. That means it suggests the importance of the oocyte DNA damage detection, repair, response in maintaining oocyte quality and quantity, and also its de novo mutation rate in the offspring. So we should pay more attention to the health of the offspring from the women with premature ovarian aging. Actually, in our center, we set up the ART-KID cohort. We are observe and do some sequencing about the children after ART treatment from the women with diminished ovarian reserve or poor response women, whether their children's their genome status compared to from the normal ovarian reserve women. So I think we will find some interesting thing. So the last part is about exploration about how to delay ovarian aging, targeting genomic instability. So since oocytes with DNA damage and go apoptosis if the repair fails, so there are 2 points. Maybe we can to do something. We can blocking apoptotic pathways or enhancing the DDR capacity to delay the oocyte loss. To decrease the oocyte loss and to delay overaging theoretically. So actually, I think some scientists have do some work. For example, we can do the CHEK2 knockout mouse, and we see that there's lower follicle depletion and extended reproductive lifespan in mouse. And also we can do TP63 novel puma KO mouse, and also exhibited the apoptosis of oocytes after the chemo or radio damage in mouse. This is editor gene KO in mouse, And also some other trial in the pharmacological interventions. We can use some methods to, for example, the inhibitors of ATM, CHEK2, or CK1, and they are the upstream of TAP63, and also we can use some peptide to inhibit TAP63. So reduce the DNA damage, reduced oocyte apoptosis will increase the survival follicle number and promote oocyte survival. Maybe some people may say, it's a DNA damaged oocyte. Should it be translated to the next generation? Actually, in mouse, it has been reported it can to bring birth to the healthy offspring in mouse, the genetically healthy. It's observed that. And also another route is to enhance the DDR capacity. Yeah, there are some expressions of CHEK1 gene or injection the red 51 protein, and also we can see increasing the ovarian reserve and extending productive lifespan also in mouse. So this theory is correct. So at present, this work still in the lab for research. So lastly, I want to make summary. So genome of female germ cell face various threats and relies on multiple DDR pathways to maintain the high level of genome stabilities. And the genomic instability is an important cause for not only the physiological, but also for the pathological ovarian aging, and it will affect the offspring health, not only chromosome level, but also the molecular level, the mutation, as well. So enhancing damage repair capacity is a potentially effective strategy to delay ovarian aging. And in the future, we want to classify the impact and the mechanism of the ovarian aging on offspring genomic stability and the long-term health. Now we observed the phenotype. So what about the mechanism and the regulation? So the second one is how to develop a safe and efficient methods or drugs to target the genomic, to enhance the genomic stability in human to improve the fertility. I think this is two important work in the future. So finally, I want to thank the Shandong University IVF team, and also thank all the corporations from international and national. And this is our SDU IVF big family, and this is our very beautiful campus. Okay, thank you again. That's all.
Spectacular paper. Thank you very much for sharing this with us. I think we heard from start to finish here, the etiology was determined. We're going to have some time for a question or two. You want to stay at the podium?
Did we discuss at the end of the trilogy together? No? I'm sorry.
So we have time for a question or two.
Oh, okay, no problem.
You know,
okay,
unlike the eponymous lecture, it is acceptable to give questions here. And
okay.
so if you have a question, please go up to the podium, to the microphone, and discuss it. My comments was that we've seen from start to finish, lots of questions could be raised in these areas. Number one, we certainly know the etiology to a much greater extent than happened 15, 20 years ago. Secondly, they are specific in terms of what they'd exist. And you've talked about the DNA repair. You've talked about the cell cycle checkpoints in terms of doing that. And then finally, you've even given us a way to mitigate this. And of course, that was to determine the exact enhancing factors and apply those in patients. So I think we have a full message about where we're going. So I don't see questions being raised, but they are certainly here. And if so, we'll have a chance to ask these questions. I have one question, though, and that is, toward the beginning, you pointed out the rare variants. Now, there was definitely a rare variance in 15 years ago or so. I don't get the idea that you believe that there are rare variants, that the variants are so rare. And so we think of BRCA1 and 2 in this category. You know, at one time we thought the single mutation that would occur would be important, but now we know that there are well over 100 different mutations that can occur in the BRCA1 gene alone. Do you think that's going to be similar to what you're going to find as we look for these other genes that we know are important for DNA repair and the likes?
Okay, very good question. Yes, I think the rare variants, actually, it's the minor allele frequency is less than 1%. Actually, there are 100 curative genes have been identified in POR. Actually, the mutation frequency also less than 2% at the most. So that's why, so we cannot define which one is the key gene for POR disorder. I think it's monogenetic mutation will result in this disorder, but the everyone is the rare variant. So I think if we want to define its genetic diagnosis or genetic causes for this patient, I prefer to do a panel instead of just 10 or 20 genes for this patient. So I think at present we still think the effect of every gene is limited. We need a panel to screen. Yeah.
So that's certainly going to be the future. That's going to be introducing further genetics in terms of this process or so. It's different than what we thought. And the only issue that I would perhaps advise, note there, is that when you're looking at this and you're looking at the reports that this group has done, you will be surprised, at least I was surprised, that most of the locations for the mutant genes were on autosomes. So X chromosomes have not gone away, but they're certainly fading right now. Yeah. So again, I'd like to thank you for what you've done and what you've shared with us today. Thank you very much.
Thank you. Thank you.
Okay, the next speaker is Dr. Elinor Charlson-Bott from Norway, Haukeland University Hospital. She is a specialist in internal medicine and endocrinology. So her primary research interest is primary premature ovarian insufficiency and Addison disease. So today she will introduce us the new guidelines for POI from ESHRE as a candidate of ESHRE guideline development group. So please start the presentation.
Thank you so much. It's fun to present news, especially when it's on my favorite subject, premature ovarian insufficiency. So as the introduction said, I'm a clinical endocrinologist from Norway with a special research interest in premature ovarian insufficiency and the immune system. So that is autoimmune causes of POI, but also how POI affects autoimmunity and the immune system in general. And I have contributed to the ESHRE guidelines. So on behalf of the guideline development group, I'll show you some news from the evidence-based guideline on premature ovarian insufficiency, POI, which was hosted by the European Society of Human Reproduction and Embryology, ESHRE, and developed in partnership with the American Society of Reproductive Medicine, Monash University in Australia, and the International Menopausal Society. I have no conflict of interest to disclose. I have the feeling that this is a very interdisciplinary audience. So I'm going to give a very brief summary of the endocrine pattern or the hormonal fingerprint of the condition we are discussing today, so we know that we are on the same page. So the functions of the ovaries are controlled by the hypothalamus and the pituitary gland. And the pituitary gland produces gonadotropins, follicle-stimulating hormone, FSH, and luteinizing hormone, LH, which stimulates ovarian hormone production. That concurrently feeds back to the hypothalamus and the pituitary gland and regulates the gonadotropin production. So we have this nice feedback cycle. And the ovaries, of course, contain follicles of different stages and consist of an oocyte and hormone-producing granulosa and Teca cells. So the function of the ovary, very easily said, is to produce oocytes for potential fertilization, but also to produce sex hormones, the progesterones, the androgens, and the estrogens. And these sex hormones have autocrine functions within the follicles, within the ovaries, but they also, of course, have endocrine functions throughout the body for sexual health, but also for general health. Loss of ovarian function under the age of 40 years leads to menstrual disturbances. Sometimes it's primary amenorrhea in approximately 10 to 15% of cases, we think, where the woman never has, or the girl never has menarche and never experiences, some of them don't go into puberty as well, but most of the women have secondary amenorrhea. They've had menstrual cycles and then they disappear. These women also have hormonal changes, whereof hypoestrogenism is most profound, resulting in an elevated FSH. So that is the hormonal fingerprint that we have to look for. So the ESHRE POI guideline from 2016 was the most cited clinical guideline on POI, but since then a lot of new data has emerged. Illustrated here by publications in PubMed. So it was time for a revision. And the ESHRE, so in the new ESHRE guideline, we used the ESHRE methodology, and a scoping survey was sent to around 1,000 healthcare personnel and women with POI, resulting in key questions, so-called PICO questions. These questions were handled by the guideline group, who did structured literary searches, and had lots of meetings, mostly online, and this resulted in 145 recommendations. And so that summarized the new evidence and the old evidence. And these recommendations we used the grade approach, which we went through earlier today here, where the evidence is evaluated as high, low, or moderate, or high quality. But in addition, good practice points, or GPPs, were used to modify or to give advice or caution where the evidence was not sufficient. The document is 250 pages long, so it's very long. And unfortunately, or maybe fortunately for you guys, I can't go through all of it, but I'll show you some highlights, and you can read the rest yourself in the book. It's very enjoyable reading. We'll go through, we'll have a special look at some things that are new with the diagnosis and initial assessment, and also look at new evidence regarding sequelae of POI, and we know more about how hormonal treatment works as well now. But first, let's just have a peek on the prevalence, because there's some news there too. The age at menopause is, as we know, quite normally distributed, with a mean range between 46 and 52 years. And earlier studies indicated a prevalence of women under 40 years of age that went into menopause approximately 2 standard deviations below the mean age of 1%. That's kind of been the the saying of what the prevalence of POI is. But more recent evidence, or more recent data in large meta-analysis, suggest that the prevalence is approximately 3.5%. And population characteristics such as ethnicity and lifestyle may also affect the prevalence, with higher prevalences than this in low-income countries, low and middle-income countries, actually. So the prevalence is higher than we thought previously. So what investigations should we do to set the diagnosis and find the cause? There are many clinically useful flowcharts in the guidelines, and I'll just try to take you through some of the important points. So the diagnostic criteria include a clinical and a biochemical criteria. So in the clinical evaluation, the woman has to have amenorrhea or disordered menstrual cycles for some time, and the time limit is set as more than 4 months. Other etiologies, of course, have to be ruled out, like pregnancy or ongoing hormonal treatment or thyroid hormone disorders and other endocrine disorders. The biochemical criteria consists of an FSH level above 25 international units per liter. And there was some discussion acknowledging the uncertainty of setting a specific cutoff level, but still, because of lacking new data, we chose to keep the cutoff from 2016 guidelines. So what is new about this is that a single FSH test is sufficient. In the old guidelines, you had to have 2 high FSH levels. This was the reason for this is that the fluctuating nature of POI with varying hormone levels, and also menstruation can come back in especially the first few years. In this setting, a second FSH may paradoxically confuse the situation and is not needed if these 2 criteria are there. But in cases of diagnostic uncertainty, a second FSH test is recommended. And other supportive tests can also be used, like anti-Müller hormone levels, low estradiol in combination with the high FSH, the hormonal fingerprint, and ultrasound showing low antral follicle counts. There was a discussion as to whether AMH should be used in primary diagnostics, but there is very little data on AMH in the POI group. And also one thing that was taken into consideration was that a low AMH might have negative implications for access to fertility treatment some places. Causes of POI. So there are several causes of POI, and we've gone through some of them earlier in the previous presentation, but very easily we can say that either it affects the ovarian reserve and or the ovarian function. And it's not unlikely that sometimes we find one cause of POI, but it's not unlikely that in many cases it's an interplay between genetics, environmental factors, and immune regulation. It's estimated that in 70 to 90% of cases, we can't find any cause, so idiopathic POI, and that's very high. But luckily, as the discussion here showed too, that there are new improved genetic opportunities that likely will reduce the etiological POI cases. So what genetic tests should be done? Obviously, a myriad of genes are involved in the complex ovarian function, as we saw in the previous lecture. underlying numerical, chromosomal, and structural deviations, especially affecting this region on the XQ arm, are well known, associated with BOI. Lately, there's been an increased focus on genetic variants or mutations. FMR1 pre-mutation is one of the more common single known causes, but there's increasing knowledge on genetic variants. So as she said, more than 100 genes we know of are involved, and all these genes have different pathogenic variants that we know can cause BOI, but also what's important is there's more focus on polygenic inheritance as well, so it's complicated. This is made very easy. All her, what she was saying before, Dr. Kidd made it very easy. So what should we investigate to be more practical? Well, we recommend chromosomal analysis and FMR pre-mutation testing, and where available, additional genetic testing using next-generation sequencing, whole exome or whole genome sequencing, and using panels, premature ovarian insufficiency panels. And there are several recommended panels available. And this is the future, so there'll be more. And there's also a few other things that we have to consider when investigating genetic causes. Age should not restrict access to genetic testing. In my country, we used to have an age limit for additional genetic testing of 30 years before, but now we've cut it out because recent observations have shown that genetic causes are underdiagnosed in the older POI women. Also, number 2 there, genetic counseling should always be considered. And that's important because it's important for the woman herself and also for the relatives. A positive family history of POI increases the risk of POI in relatives a lot. So when a genetic cause is established in a family member, then female family members should be offered genetic counseling. That's a strong recommendation. Okay, what other causes do we have? We have autoimmune causes. Inflammation of the ovaries can result in ovarian failure, ovaritis, and the target of the autoimmune attack in POI is the TECA cells. So the autoimmune infiltrate, when we look at biopsies, seem to selectively affect the TECA cells of the growing follicles and sparing the granulosa cells and the small follicles, which can be important for future treatment implications, we think. Biopsies of the ovaries are not recommended in diagnosing autoimmune ovaritis. Instead, autoantibodies against steroidogenic enzymes are used as surrogate markers. And this is important also. POI is associated with autoimmune disease. Specifically, adrenal insufficiency is 300 times more common among women with premature ovarian insufficiency than in the general population. But also other autoimmune disease like hypothyroidism. Approximately 20% of the women have hypothyroidism. Yeah, so when we test for, I was talking about testing the autoantibodies, and some places there's been tests for anti-ovarian autoantibodies or anti-steroid cell-producing antibodies, and these should not be used because they have a very low accuracy. Instead, we recommend testing for 21 hydroxylase autoantibodies in these women. Because it seems to be the most specific autoantibody for autoimmune ovaritis, and it can also be important to show if the woman has a risk for Addison's disease later on. When it comes to the thyroid function, TSH is the best measure for that, and not TPO autoantibodies, as these are very prevalent in the general female population. Among 15% of women have positive TPO without necessarily having a thyroid hormone disturbance. Okay, why is diagnosing POI important? Well, there's a number of adverse short and long-term effects, consequences of estrogen deficiency at an early age. Menopausal symptoms, of course, but also infertility, musculoskeletal disease, cardiovascular disease, neurocognitive disease, and reduced life expectancy if not treated. POI, it's long been known that estrogen deficiency at an early age is associated with osteoporosis and abnormal or reduced bone mineral density. There's an updated topic on muscle health in the new guidelines based on emerging evidence suggesting impaired muscle parameters in these women, including risk of sarcopenia. So that's new, an initial assessment with a DEXA scan is recommended, and then you should tailor the frequency of the new DEXA scan according to the results on the initial DEXA scan, not every 5 years as we said in the previous guideline. When the treatment approaches, hormone treatment is bone protective, and this evidence is strong. It's important to avoid delayed medication and also to monitor adherence to treatment in these women. So timing of menopause matters when it comes to cardiovascular health. There's women with POI have increased risk of cardiovascular disease and associated risk factors. So they should be assessed for the risk factors at diagnosis and also monitored at follow-up. And RCTs and observational data suggest cardioprotective effects of hormone treatment, and also non-use of hormone treatment is associated with increased cardiovascular events and mortality. And as in women with usual age at menopause, the timing, the initiation of the hormone treatment, and also the type of hormone treatment matters, especially the progesterone. There's more data in the new guidelines on POI and neurological function. Cognitive observational studies show that women with POI have increased risk of cognitive impairment and dementia, and also Parkinson's disease. But the strongest evidence for these conditions is from oophorectomized women under 45 years of age, not 40 years of age. But it's important to consider this when planning oophorectomies. And hormone treatment is recommended to reduce the risk. Okay, so once we have the diagnosis, the initial assessment, and the initial assessment, including risk factors for sequelae, mostly of the condition, then we should consider management and treatment. So we've looked at bone, brain, and heart health, but also sexual function and genitourinary symptoms, fertility, psychological health are also very important factors that we don't have time to cover today. But what's important here is that for all these conditions, systemic hormone therapy is the backbone of the treatment. And the previous guideline, in the previous guideline, hormone treatment was indicated to treat symptoms of POI. But this is the key message, I would say, in the new guidelines, that a systemic hormone treatment is indicated as a primary preventive treatment to reduce the risk of morbidity and mortality, whether there are estrogen deficiency symptoms or not. And these women should be treated to a usual age of menopause and then individualized treatment further on. Yeah. So summary of indications for hormone treatment. There's sufficient evidence to recommend treatment for almost all the conditions that we've talked about. There's not yet sufficient evidence regarding muscle health and quality of life. This management algorithm summarizes the steps when considering hormone treatment, and they are more or less the same as in other women at usual menopause. You have to consider if it's contraindicated, if they have any estrogen-dependent cancers, if there's need for uterus protection, and then also contraception if it's required, because 5% of these women do actually experience natural pregnancies. Yeah, there's no lack of evidence regarding non-hormonal treatment for the herbal therapies for in POI, and this is quite well documented in the guidelines for those who are interested. Otherwise, individualized treatment, many choices, mostly the same as in women at usual age of menopause, like transdermal, oral, sequential, or continuous, but and very importantly, higher doses of estrogen and also continuous estrogen if for protection of bone health is recommended. When it comes now, so okay, we've looked at the diagnosing and cause, we've looked at sequelae and management of this risk, and we've also looked at hormonal treatment, what to think of. When it comes to monitoring, an annual review is recommended, where you look at the somatic health and also the psychological well-being of the woman and adherence to hormone therapy. The frequency of monitoring bone health and heart health should be individualized depending on the baseline results. Okay, take-home message. What's new? POI is more common than we thought previously, 3.5% prevalence. Diagnostically, only one FSH test is needed, and there's updates on the genetic testing and what's recommended there. The guideline group addresses the potential sequelae, and there's a lot more evidence there that it's important for the somatic and psychological health. And also remember, hormone treatment for primary prevention, not just symptom relief. This was the guideline development group, a very competent group, I would say, and led in an eminent way by Nick Panay and Amanda Vincent. So thank you to the guideline for doing this on the course of the guideline group. I just wanted to show you this picture at the end, and that's because it's called Women in 3 Stages, and it's from Edvard Munch, who's a painter from my country, Norway. And it just reminds us that POI disrupts the transition between the stages of womanhood. And we have to think about both the somatic health, the body, but also how this can affect the woman and her identity. And there's quite a lot about that in the guideline too. So that was a little extra.
Dr. Vogt, thank you for your nice presentation and impressive pictures. So, can we time, Dr. Vogt? Okay, we have some time, so acceptable for the questions. So, does anyone has questions? Okay, go ahead.
Hi, can you comment? There is a paper in JAMA suggesting that HRT actually increases the risk of dementia and Alzheimer's.
Are you talking about in POI women now, or in general?
In general.
In general. I don't think I've read the paper you are referring to, so I don't think I can come with any qualified comment specifically on that paper. But it's different for women who prematurely have the estrogen deficiency than in other women, I would say. But,
Okay, thank you for your excellent lecture. Actually, I think I noticed that you mentioned that the prevalence of POR is about 3.5%, right? The prevalence of POR is 3.5, right? So in the new guidelines, if we, just diagnosis disease with only one single FSH test, I think maybe the prevalence will increase in the future, you know, right? And the second one I want to say, the etiology of POI is complicated very much. So if we just use one FSH exceeding 25 as the diagnosis criteria, so the etiology of this disease will be more complicated because it's very many different causes, many different factors influence the ovarian function. Actually, in our center, we established a longitude cohort in women with diminished ovarian reserve. We recruited two types of women. One group is with FSH level exceeding 15, and the other one is exceeding 25 according to POR diagnosis criteria. And after the 4 years of follow-up, we found that about 25% of women with FSH level exceeding 15 developed to POR. That means twice FSH exceeding 25. And also we found that about 30% of the women with FSH exceeding 15 and could got their own baby by ART or by some help from the doctors. I think we lower the diagnosis criteria of POR is very helpful in clinic because it will help our doctors to pay more attention to those women with the high risk or with the tend to be POR. But for the etiology study, maybe will bring us more challenge. And also, I think the idiopathic patients will be increased as well, because I think it's too complicated for this disease. Yes, that's no question, that's my comment. Okay, thank you.
Thank you for the comment.
Thank you.
Thank you very much for your amazing lecture. I would like to congratulate you once again. My question to you, when we use HT for a premature ovarian insufficiency, how long to continue?
So the guideline recommends continuing till age of usual menopause, but thereafter individualize as we do in other women.
Okay, thank you very much.
Okay, thank you, Dr. Bog. We need to next presentation. Thank you very much. So the last speaker is Dr. Kamura from Juntendo University, Japan. So he's very famous and internationally recognized for his innovative method for POI treatment, IBA. So IBA enabled to the POI patients who want to conceive their own eggs can have the children. So today he will introduce the current status and future perspectives of IBA. So please start your presentation, Dr. Kamura.
Thank you for Professor Osuga for your kind introduction. First of all, I'd like to thank Ovarian Committee for giving me this opportunity. Yeah, actually, to prevent infertility for POI patients, I believe the most important, most easy way is, early diagnosis, and then giving them the chance to preserve oocyte embryos, or giving the chance to have early pregnancy before all the and the oocyte disappear. But if they fail to have such kind of options, then they really face to hard to get pregnant. Then I hope actually I have continued to develop the new treatment for infertility and in the case of the POI. So today I'd like to going to show our current approach for IBA and also future prospect. So here's my disclosure and statement. So let's start with the current IBA. So I think I don't need to explain this one, and also this one I don't need to explain. But this slide shows the change in the follicular number in a woman's life. As you know, the primordial follicles produced during the fetal stage, and at least in vivo situation, they never reproduce. That's why the residual follicle number continues to decline by age. And if it reaches around 1,000, then follicle growth arrests, and women become menopause at around 50 years old. And in terms of the POI, the residual follicle number reaches around 1,000 before 40 years. And if we're talking about DOR, diminishing ovarian reserve, they are like a peri-POI state. Okay, and then to develop the new treatment for these patients, actually we need to realize one thing is, we have the drug to stimulate entrant follicle to be mature preoperative follicle. We can use an FSH, HMG for that purpose. But unfortunately, there's no commercially available drug to activate the dormant primordial follicle to primary stage. And also, there's no drug to be able to stimulate primary, secondary follicle to be entrant follicle. So we had an idea, is it possible to activate residual dormant follicles in a PI patient to develop a new treatment? Because even after becoming amenorrhea, they still have some residual follicles. So that's why we try to somehow stimulate or activate residual dormant follicles in PI cases. Then with a collaboration with Dr. Kuidu in SUB Sweden, now in the Hong Kong University, we found this PI3K pathway is really responsible for the activation of dormant primordial follicles. Then we have done this type of the clinical study. What we have done is, first step is a laparoscopical oophorectomy. Then we culture ovarian cortical tissue that contains residual follicles with PI3K activators. And then we actually tested so many combinations, and finally we found, actually, unfortunately, it takes 2 days, 48 hours to activate dormant primordial follicles. Then after that, because we have not established yet the method to get a mature oocyte completely outside body in vitro culture system, so we have to transfer the grafted ovarian tissue cultured after the PI3K activators. Then we using the laparoscopic surgery, and then we have done in vitro fertilization animal transfer. So we could get the first baby in the world in 2013. Now he is 12 years old, and he totally healthy, and of course the mother is healthy. Because the mother, after the delivery of the first baby, of course, she became amenorrhea, and then she had a second baby wish. So, and also we had some frozen tissue. So we have done IBA again to the patient, and luckily she could have the follicle growth again, and she could conceive second baby, and she finally got the first baby, male, and she could get a female baby, and they are so happy, and of course the mother is healthy, and all the offspring are healthy. And then during this original IVF treatment, we realized that in human takes from primordial to preoperative stage in a human, it takes around 4 to 6 months. So that's why we expect to have a follicle growth after 4 to 6 months from the surgery. But in not all the cases, but some cases showing a follicle growth before 4 to 6 months. So then this means our IBM method also stimulated the growth of the secondary follicles. in grafting ovaries. Then we have done the basic studies and finally found this ovarian fragmentation, because for ovarian tissue culture, we cut in ovarian tissue into tiny very pieces and then around 1 millimeter square. And then it's like giving a mechanical force to the ovarian cortex. And then this mechanical force led to the change in intracellular tension and facilitate the conversion of G actin to F actin, filamentous actin. And a subsequent disruption hypoxia decrease in P-up to total YAP ratios, and leading to the increase in expression downstream CCN growth factors. They are important to stimulate the early follicles. And then this secretion assisting growth factors stimulated secondary follicles, and finally we could get successful follicle growth. So in early POI-DRS patients, they still have their own spontaneous activation of primordial follicles. So that's why we thought, is it possible to stimulate residual follicles to increase the number of the antron follicles by disruption of hypoxia alone? So could this approach provide a less invasive treatment? You know, the original IBA, we have to do the 2 times laparoscopic surgery due to the 2 days tissue culture period. But based on that idea, we have developed a drug-free IBA, that means without tissue culture. So we removed the part of ovarian cortex from the POI, early stage of POI or DR patient, and then fragmented it into tiny pieces, and immediately return without doing a culture. Actually, we can complete this surgery within maybe 2 hours or 3 hours. So that makes less invasive approach, and we could get very nice pregnancy outcome at the time. So here I'm going to share with you some slides how we have done it for the drug-free IBA. The first step is removing the part of the ovarian cortex from one or both ovaries. The tip is try to remove ovarian cortex only, not touching the medulla part to avoid bleeding. And then cut into the tiny pieces inside culture dishes, and making a pockets beneath the serosal fallopian tubes and between the ovarian cortex and medulla using these type of devices. And finally, we grafted ovarian tissue cubes into the pocket. Actually, we developed the syringe type, we call it IBA cannula. You can put all the ovarian cortical cubes inside and just pushing out, at one time. Without using this cannula, we have to, return one by one, and it really took time. So that's why this is very useful. Now providing from the Kitazato company. Now I'm going to talk about new IBA. Actually, yes, in the drug-free IBA, we realized the weak effect of ovarian fragmentation on primordial follicle activation. This is the animal study using the mouse ovaries, day 10. Day 10 mouse ovaries contains primordial to secondary follicles. And then cut into 3 pieces. And we check the histology after transplanted under the Kirin capsule of recipient mice. And this is a 5-day rate after transplantation data. As you can see here, the proportion of secondary and entrant follicles were really increased as we expected. But here, the decrease of the proportional primordial follicle, that means the activation of dormant primordial follicles, is not so high. So drug-free IBA is less effective in achieving activating the dormant primordial follicles. So then to develop new, less invasive treatment that we had earlier, can we develop a method to activate residual dormant follicle using a short-term tissue culture technique? I think if we do the laparoscopic surgery, maybe we can wait 30 minutes without stopping the surgery. So we set a time, 30 minutes, the culture. And within 30 minutes, we try to find out the candidate to be able to inactivate dormant primordial follicles. And we also find a factor, but unfortunately I cannot tell the exact name due to it is in process of the clinical trial. So, but what we have done is using day 3 mice ovary. Again, day 3 mice ovary just consists from the primordial follicles, and then treated with the factor X or without factor X, and cultured 30 minutes, and transplanted in a ketamine capsule of recipient mice with respinar overreactomization to increase in endogenous FSH level to support the follicle growth after activation of primordial follicles. Then the animals were treated with an FSH just for guaranteeing, and finally we gave an HCG to obtain a mature oocyte, and then we have done an IVF ET to try to obtain healthy pups. So here's our data. As you can see here, if the ovary treated with an factor X, and that one is, this picture shows day 14 after transplantation of day 3 mouse ovaries treated with or without factor X. So here, the ovaries treated with factor X become larger. This is the kidney, and this is grafting over day 3 ovary. So if we measure the ovarian weight, as you can see here, the factor X treated ovary became heavier than the control. And if we look at the follicular dynamics by histology at day 14 after transplantation of the activating ovary, so you can see here the more decrease of the primordial follicle proportion. So that means by this factor X treatment, with cutting in small, even without cutting the small pieces, it can really, even a high effect to decrease the dormant primordial follicle. That means a good follicle activation. And also we could get increasing the proportion of growing follicles from primary to antral. And then we checked the safety or efficiency of this factor X treatment, and we found, so as you can see here, the ovary with much large antral follicle inside, and then when we corrected the cumulus complexes, the ovaries treated with factor X could have more COCs as compared to the control, and they look completely normal morphology. Then we have done IVF, and the fertilization rate, because in the control group, all the COC didn't fertilize. So that's why, of course, the fertilization rate is better in the case a group with a factor treated with a factor X. And also those embryos could develop blastocyst stage embryo. And after embryo transfer, actually that in this experiment, because we couldn't get any blastocysts from the ovaries, in the control ovaries, so we use control just obtaining from the normally ovulated oocyte. So we developed the blastocysts and then transfer. And actually, the implantation rate, embryos from obtained from the factor X treated one is really comparable to the control, and also the live birth rate is also comparable with the control, and the offspring pups is completely healthy, looks normal, and we continue to breed, and 2 generations we have checked the abnormality, nothing happened. Then we are doing a new clinical trial using this factor X, that could be within 30 minutes. Treatment, then what we can do is from POI patient under laparoscopic surgery, we can do oophorectomy, or also we can remove small portion of the ovarian cortex and treat it with a factor X for 30 minutes and the graft. So actually, to prepare the ovarian cortical cubes, what we are doing is, inside of the culture dishes, just cutting the tiny pieces. Well, it takes around 30 minutes in maximum, so that's why we don't need to wait so long time. And finally, after 30 minutes, we wash and everything and try to avoid introduction of factor X into the body, and then transfer graft into the patient. So now this study is in progress. Actually, we have collaborated in so many countries. I just showing the recent collaboration. I'm so sorry. Actually, I collaborated with so many countries, so many hospitals. I couldn't include in my presentation here, but these two countries we collaborated from last year, and Uzbekistan and Malaysia. Okay, and then finally, I'm going to talk about the next generation IBA. So it is no more IBA, in vitro activation. I can say it is in vivo activation. So the idea is surgery-free ovarian activation could be most less invasive. And idea is, of course, it's easy to consider the injection and reagent for disruption hypocine under transvaginal ultrasound. So we already, at the time, we already found a candidate molecule. The name is S1P. So this S1P is a biactive spin repeat acting on the GPCR to suppress hypocine pathway. And importantly, this S1P is a physiological substance and existing in a follicular fluid in the ovaries, even in human. So we have done animal studies to check the efficacy of this S1P to disrupt the hypocine pathway. And as you can see here, S1P increased in ovarian weight and stimulated early secondary growth. By histology, you can see here the increase in the proportion of early secondary follicle. And then S1P stimulate nuclear translocation and AAP protein in the granular cells, followed by the increase in the expression of downstream CCN growth factor that is responsible for the stimulation of early follicle. Then using the human ovarian cortical samples, we also confirmed S1P can work on a human, and then S1P increase in ovarian expression of CCN growth factor. Yes, that will be a nice story, but yeah, actually we can try to make a new drug using this S1P. But from the beginning to the end, making a new drug, it takes very, very, very long time, and also takes huge money. And actually, I asked some companies to try to help making a new drug. But yes, they are interested in it, but unfortunately, due to small market in our reproductive medicine field, finally they refused. So then what we have, I try to do differently. That means using drug repositioning. So we can skip, including a phase 1 study. So that's why we can minimize the time to develop, and also we can reduce the cost to be realized in market. So after screening with the collaboration of the other foreign collaborators, we found some potential candidates. One is a drug for ovary injection to activate the primary follicles and stimulate early follicle growth through maybe activation of PI3K and mTOR pathways. And another drug is just oral pill, okay? To activate dormant primary follicle and stimulate early follicle growth through activation, probably PI3K ARC and mTOR pathways. You know, we are finalized to completely, how to say, so find a molecular mechanism how these drugs work. And then now we are on the clinical study and hope to, publish within this year or next year. So using the last two slides, I'd like to emphasize one important thing. You know, actually, you know, I visited so many countries and introduced so many hospitals how to do the IBA. But issue is sometimes they believe, so just doing the IBA is already good enough. But realities are different, you know. They are PI patients. They have very high, you know, FSH and LH levels. So that means not easy to do the ovarian stimulation. And it's hard to get, you know, high quality or proper number of oocytes by just using just regular ovarian stimulation. So that's why I'd like to emphasize, in addition to the IBA, so it is really important to giving the patient a proper ovarian stimulation. So yes, you know, there are two steps for follicular stimulation from primordial to pre-ovulatory stage. First step is from primordial to entrant follicle. And then from entrant to pre-ovulatory follicle. So to achieve the pregnancy after the ovarian activation, appropriate ovarian stimulation followed by an IVF, ET, is really required to get pregnant. So I showed all the details in my published paper. Thank you for your kind attention.
So thank you very much, Professor Kawamura, your insightful presentation. So we have a couple of minutes. Can you have question? So does anyone have question or comment? Okay, go ahead.
Thank you very much for the great presentation. We knew that an aseptic inflammation of the ovary and revascularization is one of the reasons why we have a reactivation of the ovary. Now, the problem is, what is the role of AMH here? We know that AMH is not only there for us to evaluate the ovarian reserve. We know AMH is a gatekeeper. AMH is a kind of inhibitor of primary follicles to be recruited. So you have thousands, hundred thousands of primordial follicles, and at some point they have been recruited to become antral follicles. And AMH, as a gatekeeper, has an inhibitory impact on these primordial follicles not to be recruited as a gatekeeper. What would be the place of an AMH antagonist for these kind of patients? Thank you.
Thank you for your question. Actually, it is a great idea, and I know that some people do it that way. And yeah, but for me, the most important point currently is actually there are so many trials, like, you know, AMH inhibitors, and also the people doing the PRP injection, injecting the stem cells, exosome. There are so many different approaches people trying to do it. But again, it's the same as our IV approach. It is currently impossible to diagnose the presence of residual follicles. So even using AMH, AMH is not coming from the primordial follicles. That's why we cannot predict whether this patient has still residual follicles or not. This is actually major issues. And as you said, we'd better to do we better to develop the less invasive approaches, of course. And I bet according to my knowledge, maybe people making the, for example, neutralizing antibody or MH, or making the like a small molecule to just specific for the suppress the MH action and at a receptor level. But still, there's still some how to say difficulties to realize in the market. So I hope, including our approach, somehow such less invasive approach will help the easily and low cost to the POAC patient. But for me, the most important part doing this type of treatment is diagnosis of the residual primordial follicles or not in the POAC patient. Thank you for your question.
Thank you very much. That was an outstanding lecture. The fact that you developed this primordial follicle rapidly can induce epigenetic changes, and have you checked if there is any variation in oocyte development on that aspect?
Yes, in an animal study, we have done briefly about the epigenetic change. We have checked the briefly epigenetic changes, but in a human, well, it's a little difficult to do using the really precious eggs obtained from the patient. So that's why we haven't done it. But well, we are now monitoring for long survival and also long healthiness of the baby after born, after baby deliver, after treatment. They hope to make some important information in the future. Thank you.
Okay, thank you very much, Professor Kamura. It's time to close the session.
We'd like to officially close this session. Thank you for your attention, and thank you for our being able to observe spectacular speakers. Thank you.